Wheezing in infants and pneumonia. The objectives of this lecture are to understand the etiology, natural history, clinical features, treatment, and parental advice of how to care for a child with bronchiolitis and pneumonia. Wheezing is a musical and continuous sound that originates from oscillations in narrowed airways, heard mostly on expiration. Acute bronchiolitis is predominantly a viral disease. Respiratory syncytial virus is responsible for more than 50% of cases. Others include parainfluenza, adenovirus, other viruses, and mycoplasma pneumoniae. It's characterized by bronchiolar obstruction with edema, mucus, and cellular debris. Clinical features of bronchiolitis include infant first develops mild upper respiratory tract infection, fever 38.5 to 39 degrees centigrade. Gradually he develops respiratory distress, paroxysmal wheezy cough, dyspnea, and irritability. The physical examination of an infant with the bronchiolitis shows tachypnea, nasal flaring and retractions, fine crackles or overt wheezes with a prolongation of expiratory phase. Hyperinflation of the lungs may permit palpation of the liver and spleen. The diagnosis of bronchiolitis is usually clinical, particularly in a previously healthy infant presenting with the first-time wheezing episode during a community outbreak. Chest X-ray may reveal hyperinflated lungs with patchy atelectasis. The white blood cells and differential counts are usually normal. Viral testing is sometimes needed for research purposes. This chest X-ray shows hyperinflation of both lungs and flattening of the diaphragm, which is a classical finding of an infant with bronchiolitis. This chest X-ray shows the typical collapse consolidation of the right upper lobe usually occurs as a complication of bronchiolitis in infants. The differential diagnosis of bronchiolitis includes asthma with history of recurrent wheeze, cystic fibrosis, history of chronic diarrhea and failure to thrive, congenital malformations like aortic ring, slings, other things, foreign body aspiration, history of choking, gastroesophageal reflux, history of regurgitation and vomiting, trauma and tumors. Infants with acute bronchiolitis who are experiencing respiratory distress should be hospitalized. The mainstay of treatment is supportive. If hypoxemic, the child should receive cool humidified oxygen. The infant may be fed through nasogastric tube. Frequent suctioning of the nasal and oral secretions often provides relief of the distress or the cyanosis. A trial dose of inhaled bronchodilator may be reasonable, with further therapy predicated on response in the individual patient. Corticosteroids are not recommended. Ribavirin, an antiviral agent administered by aerosol, has been used for infants with congenital heart disease and chronic lung disease when they develop bronchiolitis due to respiratory syncytial virus. Antibiotics have no value unless there is secondary bacterial pneumonia. Respiratory syncytial virus immunoglobulin is not recommended here. The case fatality rate in bronchiolitis is less than 1%, with death attributable to apnea, uncompensated respiratory acidosis, or severe dehydration. Infants with conditions such as congenital heart disease, bronchopulmonary dysplasia, and immune deficiency often have more severe disease with higher mortality. There is a higher incidence of wheezing and asthma in children with history of bronchiolitis, unexplained by family history or other atopic syndromes. Prevention of respiratory syncytial virus bronchiolitis can be achieved by palivizumab intramuscular monoclonal antibody given before and during the RSV season. It's recommended for infants less than 2 years of age with chronic lung disease, with prematurity, and with hemodynamically significant congenital heart disease. Respiratory syncytial virus intravenous immunoglobulin can also be used. Meticulous hand washing is the best measure to prevent nosocomial transmission. Pneumonia. It's either community-acquired pneumonia, where the acute infection of the pulmonary parenchyma in a patient who has acquired the infection in the community, or hospital-acquired pneumonia, which is called nosocomial pneumonia. As you can see here in this pie chart, pneumonia constitutes 19% of mortalities in children below 5 years of age, excluding those in the neonatal period. Viral pneumonia. Most children younger than 5 years of age who are admitted to the hospital with pneumonia have viral pneumonia. Viral pneumonia does not require antibiotic therapy unless a mixed infection or secondary bacterial infection is suspected. Typical bacterial pneumonia may occur in children of all ages. Streptococcus pneumoniae is the most common type of bacterial cause of pneumonia in children of all ages. Staphylococcus aureus, Streptococcus pyogenes, Haemophilus influenzae type B and non-typeable, and Moraxilla catarrhalis are other bacteria that might cause pneumonia in children. Antibiotic regime might include amoxicillin, ceftriaxone, or cefotaxime. This chest X-ray shows the typical homogeneous opacity of right-sided upper lobe pneumonia. For atypical bacterial pneumonia, Mycoplasma pneumoniae is the most common in children older than 5 years. Antibiotics for the treatment of atypical bacterial pneumonia include erythromycin or azithromycin, and for those older than 8 years, doxycycline is used. This chest X-ray shows the typical bilateral involvement of both lungs in the lower lobes characteristic of atypical pneumonia. Nosocomial pneumonia may be caused by Staphylococcus aureus, Enterobacteriaceae, Pseudomonas aeruginosa, and anaerobes. Acceptable broad-spectral empiric regime include an aminoglycoside plus piperacillin tazobactam or meropenem, or clindamycin. For aspiration pneumonia, appropriate antibiotics regimes for hospitalized children include clindamycin or meropenem, vancomycin if methicillin-resistant Staphylococcus is considered, trimethoprim sulfamethoxazole if Pneumocystis carinii is suspected. The duration of treatment of pneumonia for uncomplicated cases is 7 to 10 days or at least 1 week beyond resolution of fever. For complicated cases like necrotizing pneumonia and lung abscess, 4 weeks or 2 weeks after the patient is afebrile and has improved clinically. Most otherwise healthy children with pneumonia recover without sequelae, even if the pneumonia is complicated. Thank you and good luck.